Thank you for your interest in surgical weight loss. The purpose of this online presentation is to explain your bariatric surgical options, introduce you to the Baptist Health Floyd weight loss team, and most importantly, help you get started. After viewing this seminar, we will ask you to provide your email address so we can contact you with more information. Dr. Lanny Gore serves as the Program Director for the Weight Loss Center. He is board certified in general surgery and is a Fellow of the American College of Surgeons. He is a 2002 graduate of the U of L School of Medicine, where he completed his residency in 2007. Prior to joining Baptist Health Floyd, Dr. Gore practiced medicine at King's Daughters Hospital in Madison, Indiana. The Baptist Health Floyd weight loss support staff includes Amy Brown, a registered dietitian, exercise physiologist, and certified diabetes educator, specializing in behavior and lifestyle changes associated with bariatric surgery. She also leads monthly support groups for our bariatric patients. Joan Weston is a registered nurse specializing in weight management and diabetes. She provides educational, medical, and behavioral guidance to all of our bariatric surgery patients. She is part of the medical team assisting patients before and after surgery. Kelly Royster is the center's practice manager. She oversees the HMR and bariatrics programs. She helps our bariatric patients prior to and throughout the surgery process. Emily Fisher is the medical office team lead and the first line of contact for our patients. She provides information to patients who have any questions throughout the surgery process. She schedules appointments and helps to ensure patient compliance. Emily may also fill in as the medical assistant. Narissa Frame is our insurance coordinator and is responsible for verifying bariatric surgery coverage and ensuring that patients have all the insurance-required documentation ready before surgery is scheduled. Elise Wagner, our clinical reviewer, is a registered dietitian responsible for keeping data on all of our bariatric surgery cases at Baptist Health Floyd. She is also an HMR educator.
Hello, I'm Dr. Lanny Gore. Each patient has their own reason for pursuing weight loss. Here are a few examples.
Suffered a fall approximately 3 years ago and didn't break anything but had sprains. I had a sprained ankle, sprained knee, sprained back, had 2 surgeries, and as a result I now have chronic back pain and hip pain. I have done everything medically indicated and now was at the chiropractor, and he thought by losing weight that would alleviate some of the pressure on my back. I didn't really take him seriously at first, but when I went back the second time he started giving me brochures. I was like, okay, he's really serious about this. He wants me to really think about that. Then I had to kind of really think about the fact that obesity is a disease. That was something, a thought process that I just had never ventured to think about before, that this really is a disease and that I'm a person who is afflicted by this disease and have been afflicted by it since childhood. So that was kind of a wake-up call for me, and that I needed to do something.
I think my wake-up call probably was when I realized that my quality of life was declining. And it was going down rapidly. I had diabetes. I had a lot of issues with my breathing, with asthma and joint issues, and life just was not a whole lot of fun to live anymore. So I realized that for me to be able to be there with my kids and to do things with my kids and to just enjoy life, that I was going to have to do something, because I didn't want to keep going the way that I was.
I live on a corner house, and I was sitting outside with my son, who was just learning to walk, and we were sitting on the lawn and just playing, and out of nowhere he jumped up and ran towards the street. And the amount of time it took for me to get up and run after him, he was already in the street. And I realized that I wasn't there to protect him, that I couldn't do it at my weight. So at that moment, I knew that I had to do something so that I could be there for him. He was only 1 year old.
We're going to talk about what is obesity, your daily challenges, what is obesity costing you, what are your surgical options, then we'll summarize and let you know what your next steps are. What is obesity? Obesity is a disease of excess fat storage with a number of associated diseases known as comorbidities. It is also multifactorial, meaning many different factors can cause obesity. It is lifelong, progressive, potentially life-threatening, and costly. What is morbid obesity? Clinically severe morbid obesity is defined as greater than 200% of ideal body weight or greater than 100 pounds overweight, a body mass index or BMI of greater than or equal to 40, or a BMI of greater than or equal to 35 with one or more severe comorbid conditions. According to the National Institute of Health, body mass index is a measure of body fat based on height and weight that applies to both adult men and women. Here are some examples of different categories of BMI. For instance, morbid obesity on this chart is a range of a BMI of 40 to 49, and severe obesity is 35 to 39. Many serious illnesses are associated with obesity. Type 2 diabetes, hypertension, which is high blood pressure, hyperlipidemia, which is high cholesterol, respiratory disease, sleep apnea, and many others that are listed here, including cancer. You're not alone. More than 65% of adults are overweight or obese. 32% of children are overweight. 4.8% of adults are morbidly obese. The total medical cost for obesity in the United States is currently over $100 billion a year. 325,000 obesity-related deaths occur annually. Many people face the same issues. Here's a chart from 1987, and as you can see in Indiana and Kentucky, 10 to 14% of the population is considered obese. When we jump ahead just 10 years to 1997, in the Indiana and Kentucky area, 20 to 24% are obese. In 2007, just 10 years later, you'll notice that in our area, 25 to 29% are obese. There are even some areas where greater than 30% of the population are obese. And if you consider that we're on the same trend by now in 2014, you would expect greater than 30% of our area's population to be obese. A high BMI can affect life expectancy. In younger and middle-aged women and men, increased BMI may increase the risk of dying prematurely. Teens entering adulthood with a BMI greater than 40 die 8 to 13 years earlier than the general population. So what is obesity costing you? Well, the Atkins diet or Weight Watchers do require some expense, and as you can see in this chart, the average weight loss after just 1 year is 5 or 7 pounds on some of these programs. These are expensive programs and contribute to the cost of being obese. Day-to-day living, such as clothing, food, and medications, also contribute to the cost of obesity. Your insurance costs may go up as the BMI goes up. Here's a chart that shows the percentage increase in costs comparing obese to non-obese patients. Physician visits and pharmacy expenses can be much more expensive as the BMI increases. What are your surgical options? Are you a candidate for weight loss surgery? If your BMI is greater than 35 with comorbidities, which we reviewed earlier as diseases associated with obesity, or a BMI greater than 40 without these comorbidities, most insurance companies consider you a candidate for weight loss surgery. You must be healthy enough to undergo a major operation. You must have shown that you failed attempts at medical weight loss in the past. There must be a consensus by a multidisciplinary team of physicians and other healthcare professionals that you are a candidate. And you must understand the surgery and risks. You must be dedicated to a lifestyle change and lifetime follow-ups. There are several surgical options available. Gastric bypass, which is a restrictive and malabsorption procedure, as well as sleeve gastrectomy, which is a restrictive procedure, and gastric banding, which is also a restrictive procedure. What are restrictive or malabsorptive procedures? A gastric bypass is an example of restrictive and malabsorptive bariatric procedure. The surgeon creates a small stomach pouch, limiting the amount of food a patient can eat. A section of the small intestine is rerouted, causing food to bypass a large portion of the small intestine. Bypassing a portion of the small intestine means the patient's body absorbs fewer calories and nutrients. Gastric banding and sleeve gastrectomy are examples of restrictive bariatric procedures.
A small pouch is created which limits the amount of food patients can eat at one time. The smaller stomach pouch fills quickly, and this helps patients feel satisfied sooner with less food. Gastric banding, sleeve gastrectomy, and gastric bypass are performed at Baptist Health Floyd.
The risks of abdominal surgery are bleeding, pain, shoulder pain, pneumonia, complications due to anesthesia and medications, deep vein thrombosis, which is blood clot of the leg, and injury to the stomach, esophagus, or surrounding organs. Also infection, pulmonary embolism, which is a blood clot to the lung, and even death. Risks of bariatric surgery include abdominal hernia, chest pain, collapsed lung, constipation or diarrhea, dehydration, enlarged heart, gallstones or potential gallbladder issues, gastrointestinal inflammation or swelling, stoma obstruction, which would be obstruction of a portion of the stomach or intestine, stretching of the stomach, the surgical procedure needing to be repeated, and vomiting and nausea. Adjustable gastric banding is one type of restrictive procedure. It is laparoscopic, meaning we are operating through small incisions in the abdomen. It is the second most frequently performed bariatric procedure. It has a mean excess weight loss at 1 year of 42%. It requires an implanted medical device and has the lowest rate of complications. The Realize adjustable gastric band is actually two medical devices. The Realize band wraps completely around the upper part of the stomach and is designed for your safety and comfort, and one size fits all. The Realize injection port attaches to the abdominal wall, has a wide septum designed to make band adjustments easier, and minimizes bulge as you start to lose weight. Both devices are made entirely from biocompatible materials. The Realize adjustable gastric band molds the stomach in two connected chambers. It has a strong, flexible silicone structure and a 360-degree coverage on the stomach for maximum comfort and minimal dysphagia, which is a word that means problem swallowing. The inside of the band has a soft balloon, and the balloon can hold up to 9 cc's of saline. There's a low-pressure balloon designed to reduce tissue trauma. The Realize injection port is approximately half an inch high to minimize bulge as you start to lose weight. The injection port can be fastened to abdominal wall in less than 1 minute to minimize the patient's time under anesthesia. The injection port fasteners are 66% stronger than sutures. Top of the port has a sturdy silicone layer called a septum. During band adjustments, saline is injected with a needle into the port through the septum.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are placed through the trocars into the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. In preparation for the band, a tunnel is created behind the stomach. The Realize band is introduced to the abdomen through a trocar. The Realize band is positioned around the upper portion of the stomach and then secured using the locking mechanism. A tube attached to the Realize band will be connected to the injection port. The port is used to adjust the band tightness after surgery. An incision is made on the upper abdomen to insert the Realize injection port beneath the skin. The tube is secured using the locking connector on the port. The injection port and tube are placed beneath the skin. The Realize band does not alter your digestive function. Food consumed passes through the digestive tract in the normal route. Your surgeon may tighten the Realize band by injecting saline into the injection port. As the saline is introduced to the Realize injection port, it travels through the tube to the band. The addition of saline to the band creates a smaller upper stomach pouch. This smaller stomach pouch restricts the amount of food you can eat before feeling full. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
What are the risks and complications of gastric banding? You could have migration of the implant, causing band erosion, band slippage, and port displacement. There are tubing-related complications such as port disconnection and tubing kinking. There is band leak, port site infection, esophageal spasm, gastroesophageal reflux disease or GERD, and inflammation of the esophagus or stomach. Your weight, age, and medical history play a significant role in determining your specific risks. Your surgeon can inform you about your specific risks for bariatric surgery. Situations where the risks are greater than the benefits that would be gained from surgery are contraindications. These include inflammation of the digestive tract, including ulcers, severe esophagitis, or Crohn's disease, severe heart or lung disease, upper digestive tract bleeding conditions due to enlarged or fragile veins, portal hypertension, abnormal digestive tract anatomy, cirrhosis of the liver, and chronic pancreatitis. Also, infection of any type anywhere in your body, known allergies to implant materials, using steroids for a long period of time or within 15 days of surgery, currently pregnant, younger than 18 years of age, unwilling to make significant changes in eating and behavior patterns, conditions or behaviors that would make it difficult to appropriately follow direction, drug, smoking, or alcohol problems, and uncontrolled psychological condition. What can you expect after gastric banding? Well, recovery takes time and patience. The diet is strict, especially immediately after surgery. The capacity of the food you eat has changed. An overnight hospital stay is required after surgery. You may experience discomfort and pain as your body heals. Length of time to return to normal activities can vary from patient to patient. Your healthcare team will advise you when to return to work and resume prior activities. Lifestyle changes are necessary to ensure success. Band adjustments are performed periodically to adjust the tightness of your band. Most patients are ready for their first band adjustment about 4 to 6 weeks after surgery. The exact timing will depend on your progress. If you are losing 1 to 2 pounds per week, you may not need an adjustment at that time. You must attend bariatric support group meetings monthly. Now let's talk about vertical sleeve gastrectomy. It's another restrictive surgery option. It is performed laparoscopically. It is now the fastest growing bariatric operation performed in the United States. It has a mean excess weight loss at 1 year of 59%, meaning that on average, let's say you were 100 pounds overweight, you could be expected to lose approximately 59 pounds. There is no implanted medical device in the sleeve gastrectomy.
The sleeve gastrectomy is a restrictive procedure, which limits the amount of food you can eat by reducing the size of your stomach. To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. Surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes to help break down the food into a more simple form, so that it can be more easily digested and absorbed once in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 to 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. The newly created gastric sleeve is able to hold approximately 1/10 of what the stomach was able to hold before. This smaller stomach sleeve restricts the amount of food you can eat before feeling full. The bile and pancreatic fluids from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments necessary for the sleeve gastrectomy. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
What are the risks and complications of a vertical sleeve gastrectomy? Abdominal hernia, chest pain, collapsed lung, constipation or diarrhea, dehydration, enlarged heart, gallstones or potential gallbladder-related issues. Gastrointestinal inflammation or swelling, stoma obstruction, stretching of the stomach, having to have the surgical procedure repeated, vomiting and nausea, and leakage of gastric contents, also bleeding. Again, your age, weight, and medical history play a significant role in determining your specific risks. Your surgeon can inform you about these specific risks for bariatric surgery. What can you expect after vertical sleeve gastrectomy? Again, the diet is strict after vertical sleeve gastrectomy. Especially in the early days, you may only be on a liquid diet for a couple of weeks. One of the advantages of vertical sleeve gastrectomy, however, is that many patients are not hungry, and we believe this is due to the decreased amount of a hormone called ghrelin. With decreased circulating ghrelin in the bloodstream, you're less likely to feel hungry. The capacity of the stomach has changed. You're only able to eat a small amount of food at a time before feeling full. You may experience discomfort and pain as your body heals. There is a 1 to 2 day hospitalization stay required. Your healthcare team will advise you when to return to work, resume prior activities, and schedule your follow-up appointments. You must attend bariatric support group meetings monthly. Now let's summarize what we've talked about. Choosing the procedure that's right for you has several considerations. Your age, your health risks, depending on comorbidities, the amount of weight to lose, your lifestyle, and eating behaviors. It's a mutual decision between patient and surgeon. Discuss with surgeon during initial consultation, and discuss with your family and friends. What can you expect after weight loss surgery? As you can see in this chart, with diet and behavior modification, the average weight loss is 8 to 12%, or just 1.6% over a 5-year period. With gastric bypass surgery, it could be up to 100% in 5 years. With laparoscopic adjustable gastric banding, 56%. With laparoscopic vertical sleeve gastrectomy, the average weight loss per year has been shown to be 59 to 66%. And because it's a newer procedure, we don't have all the 5-year data yet. The average hospital stay for laparoscopic gastric bypass surgery is 2 to 3 days. For laparoscopic gastric banding, 1 overnight stay, and for laparoscopic sleeve gastrectomy, 1 to 2 days. How well does bariatric surgery perform at resolving comorbid conditions or diseases associated with obesity? Well, following bariatric surgery, most patients resolve or improve their comorbid conditions. In this chart, we can see high percentages of people who have either resolved or at least resolved or improved diseases like diabetes, hypertension, sleep apnea, and high cholesterol. Surgery can help change your life. It improves or resolves obesity-related illnesses, it decreases mortality risk, and reduces healthcare utilization and direct healthcare costs. Remember, surgery is a tool that requires your strong commitment to a lifestyle change and lifetime of follow-up.
I'm not as tired anymore. I seem to be able to accomplish more things in a day. I can do more things with my son. My back pain is not as bad as it was in the beginning because I am working out 3 times a week with a trainer, and these are the hardest workouts I've ever had in my life, and I'm surviving them. That's incredible. Before, after my fall that I suffered, I had problems with swelling joints, swelling ankle, not had any swelling, and I think I can contribute that to the weight loss.
I was on medicine daily for diabetes. I was on 6 or 7 different medicines for my different asthma problems, my different joint pain. Now I'm on 1 medication, and it's not for diabetes, and it's not for asthma. I just take something to control allergies now. That helps financially greatly, but it gives you just a better overall sense of well-being. And I think to be healthy, to be truly healthy, you have to be healthy physically and mentally. So the two work together, and it just even gives you more of a boost, and you can just get so much more success from it. I
had all kinds of problems. I was on 2 blood pressure medicines. My blood pressure now is down to normal. I was on an antacid because I had acid reflux from the pounds of sugar I was eating. I had sinus pills because I had the CPAP. I don't have to use anymore. I don't have sinus problems, so I'm through with the machine.
It's changed dramatically. My life has changed so much for the better. I feel like a person again. Little things like getting on an airplane and flying. I just feel like a person again. I love shopping. I love hugging my children and running and playing and walking and all the things that I wasn't able to do for such a long time. I just feel like a person.
What are your next steps? You've already taken the first step. you've attended a seminar. You also return completed patient packet and copy of insurance cards for benefit verification. You have to undergo a psychological evaluation, obtain referral from primary care physician, undergo nutritional evaluation and counseling with our dietitian and nurse, have preoperative testing and physician consultation. You'll also undergo an initial consultation with your surgeon, including esophageal gastroduodenoscopy or EGD, which is a brief outpatient procedure using a scope to investigate your stomach to make sure you have no reason to not undergo the surgery. Then you'll obtain insurance authorization, which we will assist you with. You'll then undergo surgery and then undergo a lifelong follow-up appointments and support groups. Requirements for approval depend on your policy. Most of them require a BMI of greater than 40 or greater than 35 with significant comorbidities. Documented history of medical weight loss attempts from 3 to 6 months. 5-year weight history, psychological evaluation, and nutrition counseling. We are here to help you. We will verify your coverage benefits, review your specific plan requirements with you at your first visit, provide examples of documentation required by insurance, and submit your documentation for insurance approval for surgery. However, patients' active involvement is very helpful in moving the process along.
For more information, contact us at Baptist Health Weight Loss. We are available Monday through Thursday, 9 a.m. to 5 p.m., and Friday, 9 to 1 p.m. Our phone number is 812-949-7151. You can also email us at hmr@bhsi.com. We are here to help you achieve your weight loss goals.